meets precision and compassion meets courage. That's when true cancer care happens. Today, we have the privilege of welcoming a surgeon who beautifully embodies this balance. Dr. Saudamini Nayak, ma'am, she is not just a surgeon, she is the breast oncoplastic and reconstructive specialist who believes in treating the disease, body, and the person as whole. With over 9 years of surgical experience and 5 years of dedicated expertise in breast cancer, her work reflects excellence, empathy, and innovation. Trained across India and UK, Dr. Nayak has served at a prestigious institute including King's College Hospital London, University Hospital Leicester, and Amrita Hospital Kochi. She holds globally respected credentials such as FEBS in breast surgery and MRCS from Royal College of Surgeon and has been recognized with a distinction in FEBS breast surgery. Her surgical expertise spans from breast conservation and advanced reconstructive techniques to risk reducing surgery from hereditary breast cancer, including BRCA mutation. Beyond the operating room, she is deeply committed to patient safety, ethical decision making, and advanced communication, which are crucial pillars of modern cancer care. An academic contributor and award winner, Dr. Nayak ma'am is also a co author of a landmark book chapter on CreateX trial, reflecting her strong engagement with evidence based practice. Above all, she stands for holistic, patient centered breast care, where survival, dignity, and quality of life go hand in hand. It's absolute honor to welcome Dr. Saudamini, ma'am. Welcome, ma'am.
Thank you so much for that introduction. I'm feeling very proud reflecting on, my career journey. Thank you so much, Shweta. Anybody else is going to speak next, or am I okay to start?
No, ma'am, we can carry on.
Okay, fine. Right. So, yes, I have worked in cancer for a while now, nearly 7 years, and exclusively in cancer, that is as a surgeon. And majority of my work is in breast cancer. So, breast cancer is, as you know, the most common cancer in women worldwide and also in India, especially in urban India. So today's talk is going to be a general talk on cancer prevention and screening. I'm not going to focus only on breast. We're going to talk about the concepts of cancer prevention, why cancer prevention is important, and what are the ways in which we can think about preventing cancer. And we'll talk about cancer screening, the concept of cancer screening, which is specifically focused on our country, that is India. So learning objectives for today's lecture are to understand the cancer burdens. Very briefly, we'll look at how much cancer exists in our country, explain the levels of cancer prevention, identify preventable cancers. We know that some cancers you cannot, prevent, but there are a sizable proportion of cancers that you can prevent. Identify them, okay? And describe the screening strategies that are applicable in our country, in our community. And then, of course, you guys are young doctors. Once you go back into the community, once you go back into the hospitals, you should be able to apply these skills on your patients. So, talking about the burden of cancer. So, because this is a 1 hour session, okay, now it is reduced to like 40-minute session, but still a long duration. I would like some engagement from the audience itself. Okay, so the students who are listening or the doctors who are listening, so please pitch in your ideas and pitch in your thoughts as well. Let us keep it informal. Let's not make it very formal like a conference or something. So thinking about the cancer burden in India, you know that India's population is one of the largest, okay, in the world. And we also have a very large number of youth when compared to other countries in the world. So thinking about such a large population, it's only natural that, we'll have more cancer, more people, more cancer. And if we have more young population, more cancer in young people. So the burden of cancer is quite large. And in the last 20, 30 years, the number of people being diagnosed with cancer is rapidly increasing. Back in those days, maybe like 30, 40 years ago, cancer in India was not very significant when you compared it with the Western population. But now, because our economy is improving, because our lifestyle has rapidly changed, because there are more young people in our population, cancer also has increased. 15 lakh new cases annually. Can you imagine that? So think about in the next 5 years, what is the burden? It is 15 into 5.
This meeting is being recorded.
So 4 lakh deaths. Nearly 20-30% of them die every year. Okay. Incidence is increasing. 70% of the cancers are preventable. This is very important. 2/3 of the cancers that we diagnose, we can actually prevent that. That means we can actually reduce the number of new cancers if we prevent the risk factors. We take care of the risk factors and prevent the cancer. Many of our cancers are diagnosed at an advanced stage. They are not very small. They are not, cancers that you can, do an operation or give some chemotherapy and you will be cured 100%. The majority of the cancers are at advanced stage where they have spread to other parts of the body, and actually achieving cure is difficult. High burden of tobacco-related cancers. 40% of our cancers are just related to one risk factor, and that is tobacco. All right. It's a major public health challenge. Cancer is the new heart attack. Back in the days when heart attack used to be a very common thing that used to kill people, now it is cancer. It has nearly overtaken cardiovascular disease. And on the right side, you can see this bar diagram. You can see on the top, it is the type of cancer that is commonly diagnosed in India in men. This is from 2024. Look at lung cancer, mouth cancer, okay? If you exclude prostate, all of the cancers, nearly 6 cancers are associated with tobacco use alone, all right? And look at the bar diagram representing cancers in females in 2024. Breast cancer is nearly 1/3 of the total burden. Next is cervical cancer, and then the ovarian and uterine cancers. Mouth cancers are also common in some areas, especially in the rural areas, where tobacco chewing, tobacco smoking, and betel nut usage is common in women. Now, let us think about how to go about, preventing cancers. Prevention is better than cure. Yes, always, more so with cancer. But how do we, let us just think on our own and define what prevention means with regards to cancer. Think of a 50-year-old bus driver who is chronically chewing tobacco and betel nut, and he presents to the clinic with a non-healing ulcer on his tongue for 3 months. Can anybody tell me what are the risk factors in this person that are associated with his condition? It's pretty easy. Is everyone muted?
Chronic tobacco chewing, ma'am.
Yes. Chewing for a period of time, yes. And if the person is also chewing betel nut is hard, and there is small microscopic injury, constant injury to the mucosa. All right. So these are the risk factors. How could this have been prevented in this person?
Tobacco cessation or oral health education, lifestyle modification.
Who should have done that?
Us as clinicians.
So that is only if he comes to the clinic.
Public health workers.
Okay, public health workers, yes. But before the person actually, normally in India, people don't make contact with health workers or clinicians or healthcare, personnel unless they have a problem, isn't it? Even before tobacco became a problem, we could have prevented it by increasing awareness. Okay, maybe when this person was young or as a part of his education, lifestyle related awareness and awareness about the risks of tobacco, isn't it? And could this have been detected early? Can you imagine a scenario where you would detect this ulcer or this cancerous growth on his tongue early?
The non-healing ulcer, ma'am.
So this is now a cancer, okay? Could we have detected this a bit more earlier than this stage? Maybe a precancer stage?
Yes, ma'am.
Hypoplakia.
Very good. So even before the symptoms set in, isn't it? Even before he actually noticed a symptom in his mouth, it could have been possible to identify it through screening. Okay, so cancer prevention, the aims of cancer prevention are to reduce incidence. We want to bring down the number of cancers per year in our country. Okay, reducing the incidence, that is. Second is to detect it early. If at all they develop cancer, in some people you cannot prevent it completely. If at all they develop it, we want to catch it at a stage that is very early and it gives them a complete cure. That means that allows them to live recurrence free, cancer free for a natural period of their lifetime. The third thing is to improve survival and quality of life. Even if they are treated, even if they get a cancer, you treat it in such a way that they'll be able to go back to working, earning money, looking after their family, and contributing to society. Isn't it? If you think about it, when a majority of the working population in a community or in a country is affected by cancer, think about the burden. It's not just burden to the individual or family, but as a society, it is a burden, isn't it? Our healthcare system, our public healthcare system, where the resources are less, even the private healthcare system, it gets overloaded. It becomes difficult to provide good quality care when the number of cases are too high. And our system, our society also faces the backlash when young people who are in their 30s and 40s are diagnosed with cancer, advanced cancer. They have poor quality of life. They won't be able to work. When they're not be able to work, then the government will have to take on the burden of that unemployed family, or give benefits to them, spend more on care, because advanced cancer requires more intensive care. So all of this is a burden to the person, the individual, the family, the society, as well as the country. Can anyone tell me about what levels of cancer prevention are there, or prevention in general for any disease? You must have read it in your, community medicine textbooks. What are the levels of prevention? How do you prevent a disease? At what levels can you prevent a disease? Primordial, primary, secondary, and tertiary. What is primordial prevention? Anybody?
Before the onset of risk factors.
Can you explain that? Give me an example, and can you explain that, please? Maybe use a scenario or example or a situation. Maybe just take this person who is 52-year-old and he has
Maybe we could have done awareness campaigns against tobacco chewing, so that he wouldn't.
Is that primordial or primary? Even before the risk factors emerge, you said that correctly. Primordial means the risk factor has not yet entered the society. Okay? Tobacco, trying to wean people off tobacco, increasing awareness about tobacco, related cancers, you have to go one step before that.
Anti-smoking laws.
That is primary prevention. Primordial is basically a broader view. Okay, it focuses on social, economic, and environmental conditions to prevent the risk factors from, first of all, coming into our society. Okay, educating. Sorry.
Elimination of polio virus.
Sorry, say that again.
Elimination of polio virus, like in general case, eradication of the polio virus. Can that be primordial?
So that is through vaccination, isn't it?
Yeah.
So through vaccination is primary prevention. Through vaccination is primary prevention. You're preventing poliovirus is existing in the society, and you're vaccinating to improve immunity and break the chain of transmission. And that's how you are preventing it. So that is primary. Primordial is, think about a community where you are, where there is less poverty. Okay, you've reduced poverty, you've improved their nutrition levels, you have improved your town planning is excellent, sanitation is better, the air is clear, and all these individuals are aware of health in general. They know that they can look after themselves, they know how to look after their health, and they have good healthcare system. So this is a more wider and a more comprehensive look at how a society should be to prevent emergence of risk factors. Okay, imagine if there is less poverty and good nutrition, then diseases in general are less. Okay, infections are less. And when there is high levels of employment, when there is less poverty, less deprivation, then high risk behaviors like drug use, alcohol use, and smoking is also less. So you've gone one step before primary prevention. All right. Now, coming to primary prevention, the examples that you have given are primary prevention, wherein risk factors are already there in our society. Okay, people are engaging with these risk factors, and now you are going to intervene with awareness, with helping them with smoking cessation, helping them with reversing some of their habits. All right, you're giving them vaccination to prevent the transmission of infection. If they already have infections, you're treating that infection so that it does not progress to become a cancer. So the risk factor is there, and you're intervening before that risk factor actually causes cancer. Is it clear?
Yes, ma'am.
Yes,
Okay.
ma'am.
Yes. So I've given some examples here on the slide. For HPV, HPV is human papillomavirus. It's a very common culprit with CA cervix, CA anal canal, CA oropharynx, and nearly 20 to 25% of the cancers in India are associated with infections. Can you think of any other infections that cause cancer? Other than human papillomavirus?
Epstein-Barr virus.
Epstein-Barr virus.
Okay. And who is at risk of
Hepatitis B.
getting Epstein-Barr virus? Okay, Epstein-Barr. What else? What other more common?
Ma'am, hepatitis B virus.
Very good. Hepatitis B and C. What does it cause?
Hepatocellular carcinoma.
Very good. Okay, hepatocellular carcinoma. Anything else? HIV. HIV also increases the risk of cancer. Okay, so the risk factors are there in the society, they are being transmitted in the society, and you are trying to intervene so that people either get vaccinated or they don't indulge in behaviors that increase their exposure to these risk factors. And in people who are already having HBV or HPV, or for example, any other disease, you manage that disease well in such a way that they don't progress to get cancer. Okay. Environmental and occupational, can you tell me some cancers that are associated with people's occupation, for example?
Ma'am, lung cancer.
Associated with?
Workers with pollution, ma'am.
Yes, asbestos. Asbestos is known to cause, mesothelial cancers, which is pleura. Okay, lung and pleura. And yes, people who work, like women who work with firewood in closed. Sorry.
Bladder cancer in dye factories.
Very good. Tar, dye factories, people who work with tar also have bladder cancer and testicular and scrotal cancers. Okay. Again, like you can't specifically say this specific chemical in air pollution, but people who live in polluted environment, even like, for example, in Northeast, the communities there, they smoke their meat. Okay. They hang meat in the room, in their house, in one of the rooms in the house, and they smoke it for days. That is their cultural or ethnic way of treating their food and storing their food. And people who are exposed to this have higher risk of developing aerodigestive cancers. All right. So primary prevention is when the risk factor is there, but you are intervening in such a way that either at a cancer stage or before that, you are intervening to make sure that the carcinogenesis does not occur in the person. And that way you're reducing the risk. Now, as we discussed previously, we will look at some of the common risk factors and cancers. So just take a look at tobacco, okay? Smoked and smokeless tobacco, upper aerodigestive, the entire airway and entire upper digestive system is at the risk of cancer. It can be pharynx to nasal, oral, esophageal, laryngeal, lung, okay, bronchus and lung, and stomach cancer. They're all associated with tobacco. Alcohol. Alcohol is associated with, again, upper aerodigestive, liver cancer, pancreatic cancer. Sorry about the spelling there. Breast cancer. Any alcohol usage, it's not like, moderate drinking is okay, only heavy drinking causes cancer. Now, the evidence says that any amount of alcohol intake, it may be like a few drinks once in a while, social drinking, any amount of alcohol intake is associated with an increased risk of cancer. And infections, we've just discussed that. HPV causes at least 4 to 5 different mucosal cancers. Okay, so oropharyngeal cancers and anal cancers are more common in homosexual communities. Obesity. So on the left, you can see this man with variety of nomenclature, and look at how many cancers obesity is associated with. I think it is as bad as tobacco smoking, or probably worse. Don't you think so? It's associated with breast cancer, esophageal cancer, multiple myeloma, renal cancer, gallbladder, pancreatic cancer, and colonic and rectal cancer. And in our environment, radiation that we are exposed to, say, for example, in medical field, people who work closely with ionizing radiation are, at risk of developing cancer. People who have taken radiation for treating something else, like lymphoma or something, they have a higher risk of developing thyroid and breast cancer because these glands are exposed to ionizing radiation and ultraviolet rays. UV rays make people with, people who have white skin more vulnerable to skin cancer. But even in India, people who work outdoors, like farmers or construction workers, if they don't protect themselves, UV rays over the years can cause skin cancer. Among all of these risk factors, let us think about what we can control. Okay? Modifiable and non-modifiable. Can you tell me about, I think modifiable we've already discussed. We've discussed about, lifestyle changes and managing body weight, controlling substance use, vaccination, using protective gear when we're dealing with toxins. All of these things are within our control, aren't they? We can change ourselves and hence we can reduce the risk of cancer. What are non-modifiable risk factors, please? Can somebody enumerate them quickly? Non-modifiable?
Genetic factors or hereditary factors.
Yes. Example?
Inherited mutations like BRCA1, BRCA2 for breast and ovarian.
Is it possible to change them?
No.
We cannot change our genes. We cannot change our parents. What we are made up of, our DNA, we cannot change. These are non-modifiable. Next, what else?
Gender.
Okay. Can you explain?
Some cancers are gender specific. Like for males, it's prostate, and for females, it's
breast cancer and
cervical cancer.
Yeah, that's true. Anything else? Aging. Aging is a big risk factor. A lot of people don't think about it. Aging is so natural to us. And, it's a part of life. It's something that we cannot change. But aging is a big risk factor for cancer. Why is that? Quickly, in one line, somebody. What does aging do to our body that makes it, more vulnerable to cancer?
Is it mutation?
Immunity, ma'am.
Yes, immunity goes down. The ability of your body to regenerate goes away, not reduces. Okay, DNA breakages, DNA, damage is more common, and because of this, mutation is more common in aging. Whereas in young people, they have the ability to repair their DNA. Their immunity is robust, and that's why tumorigenesis or carcinogenesis is lesser. Okay, reproductive choices. Does anyone want to talk about these? Why our reproductive choices? Do you think reproductive choices affect or increase our risk of cancer? Quickly. Anybody?
Homosexual men are having more chances for AIDS, so Kaposi sarcoma.
The homosexual group have a higher risk of what? Sorry, what sarcoma?
Uh, Kaposi sarcoma, which is related to AIDS.
Kaposi sarcoma. Yes, okay,
Kaposi.
that's good. What about reproduction? Reproduction means having babies.
Pregnancy reduces the risk of uterine and ovarian CA. Uterine CA maybe.
What about breast?
Ma'am, early pregnancy reduces the risk of breast cancer as compared to late pregnancy.
Number of pregnancies, early pregnancies reduces the risk of breast cancer. Breastfeeding reduces the risk of. Yeah. Is this modifiable or non-modifiable? Is this in our control or not in our control?
Think it is modifiable, ma'am.
Okay, anybody who can tell me otherwise? Think about it. Will you tell your patients to get married early and have more children and breastfeed to prevent breast cancer? Will you give them that advice? Or is it a more complex decision? It is complex, isn't it? At what point a person decides to get married or has a partner or has babies is beyond their complete control sometimes. Yeah, a lot of things like the society, the family, the culture plays a role in it. In Western societies or in societies where women are very economically, progressive, they might, their jobs or their, financial liabilities might prevent them from having children early. They might want to study, they might want to build a career, and then go on to have children. Sometimes you just have to wait until you find the right person. So all of these things are very complex. So reproductive choices are in some ways modifiable and in some ways non-modifiable. Okay, hormone exposure as well. When we attain menarche and when we are going to have menopause is not really in our control. We know that, early menarche and delayed menopause is a risk factor, but to what extent we will be able to modify or control it to prevent cancer is a question mark. Okay, so these things are not entirely in our control. So we've talked about primordial prevention. We've talked about primary prevention. Now, secondary prevention. What is secondary prevention? Give me an example of secondary prevention. Let us just talk about the bus driver, okay? With regards to his story, can you explain to me what secondary prevention is?
Early detection and treatment.
Early detection and quick treatment, okay, to stop the disease. Now, there is a risk factor. The risk factor has caused the disease. The tumor has already started, tumorigenesis, but you are catching it at a point in which you can actually, it is early stage, and you are treating it in such a way that it does not harm this person in the long run. That is secondary prevention, early detection and prompt treatment. In India, majority of the effort now is focused on secondary prevention. Okay. And you aim for complete remission and reduce the risk of recurrence. You want to make the person cancer free and get back to normal life. Example is screening for breast cancer. Screening when, patient is not yet symptomatic. The cancer has started in the body, but they don't have any symptoms. That is Secondary prevention, self-breast examination, clinical examination, mammogram, etc. for people who are in the age group and the gender that is at risk. Tertiary prevention is to limit the damage. Okay, now the damage has already happened, the cancer has already come, and the cancer is slightly advanced stage, and now you have to do some firefighting. You have to try and reduce the morbidity and mortality and impact of the disease on the patient and their family. So you want to give them some treatment to control the cancer, treat the cancer, but for as long as you may not be able to prolong their life, but you want to improve their quality of life. For example, you want them to be able to go back to work for as long as they can, for them to be mobile, for them to be able to earn a living and look after their family. So that is a quality of life. Cost burden, think about this. The amount of, the more advanced the cancer is, the more intense the treatment is. Okay, small cancer, early stage, the cost is less and less intense therapy is needed. Maybe just a surgical excision is enough. Okay, but the more advanced the cancer is, more intense the therapy is going to be. The cost burden on the individual, the family, and the system, the community, all of that adds up. You can think about it. If there's a sole earning member who has an advanced cancer that is, morbid, painful, and needs chemotherapy, radiation therapy, palliative therapy, and all of that, he or she will not be able to provide to their family, and the after effects of that are significant. You must have seen all of these scenes in the movie theaters when they talk about tobacco chewing. Sadly, it's only the movie theaters that we see these things on. They're not there on any of the OTT platforms, any of the channels at the moment. The care becomes complex when the disease is advanced. Can you define screening, one of you, quickly? What is screening?
Ma'am, it's a test for apparently healthy individuals to identify those who are at risk of the disease.
Give me an example.
Like for breast cancer.
Okay, or diabetes or hypertension. It is normal people. Normal people somewhere, around you, you invite them for a test to look for disease. You're looking for a disease here, okay? They're completely healthy. They don't have any problems. They don't have pain or difficulty in eating or anything. They're healthy and happy, apparently healthy and happy, and you're inviting them for screening. And there are two types of screening broadly: population-based and opportunistic. Can somebody define these for me? What is population-based screening? Do we have population-based screening in India? What do we have in India? Opportunistic or population-based?
Opportunities.
Opportunistic, yes. Population-based is where all of the population is systematically screened. For example, in the UK, all women in UK who are on their 50th birthday, they get a letter saying that, happy birthday, you have turned 50, you are invited to so-and-so screening center for your mammograms. This is for breast cancer. Okay, so all women get it. Whether they choose to go or no is different, but it's a systematic screening program in which all individuals at risk are identified and they're invited for screening. All right. In India, that is really, really challenging. We've got a very heterogeneous society. Our healthcare awareness, our affordability, and our resources are so limited and so diverse that population-based screening is difficult. It's challenging. Okay. Opportunistic screening is a person has walked into the clinic for something else. Okay. Maybe they have period related problems. Okay. If there's a lady who goes to gynecologist for a period related problem or menorrhagia or something, that is an opportunity to educate her and screen her for cancers that are common in her age group. So if she's over 40, the gynecologist will examine her and say, okay, you're fine. These are your medications, but you're over 40 and you are at risk of having breast cancer. There you go. I'll write you a mammogram. Please get this mammogram done. Or she might just do a breast exam. Although breast is not related to anything that is happening with her and her health, a general breast clinical examination is done on individuals who are at risk. That is opportunistic screening. In India, largely, we depend on opportunistic screening. Okay? What are the criteria? Can you screen for all diseases? You can't. Okay? You can't. It is chaotic, and sometimes if it may not really benefit either the population or it might not improve their health. So to screen for a disease, if you have to do a test to screen for a disease, there are certain criteria that the screening test has to meet. One is that the disease has to be an important public health problem. Okay, the disease should actually affect a large number of people, and it should be of interest for the community health. Second, we should know the natural history of this disease, how this disease starts, how it progresses, and how to treat it. We need to know the exact disease process. For example, colon. Okay, you eat bad diet, the mucosa in your colon is becoming damaged. There is chronic mucositis. There is polyp. The polyp, continues to grow. Initially, it is benign. Then it becomes carcinomatous, and then it turns into full-fledged cancer. So it is a process. We need to know the natural history. Only then can we screen and catch it early. If we don't know how this cancer starts and how it progresses, at what point will you screen them? We would never know. Okay, so the natural history of the disease has to be well established and known. The test has to be acceptable to the population. Okay, it shouldn't be a very complicated test which takes hours and is very painful with multiple wires and needles going inside their body. Do you think people will, normal, healthy people walking on the street, do you think they will come and get this test done? No. Okay, it has to be safe, simple, and acceptable, culturally acceptable as well. Treatment has to be effective. If you screen and catch all these diseases, all these cancers that have no treatment, is there any benefit? What do you think about this concept? Effective treatment should be available when you're screening for a particular cancer. Why is that? Can somebody make a comment on it quickly? What about cancers that don't have effective treatment? Can you give me an example of a cancer that doesn't have an effective treatment?
Pancreatic cancer.
Okay, very good. Pancreatic cancer. Yeah, so why is pancreatic cancer not a part of our national screening program?
It has poor prognosis.
Okay, so what? Even if they live 6 months longer, why can't we screen? Instead of 4 centimeters, if we catch it at 2 centimeters, isn't it going to be of benefit? Oh.
If
Is it
there
good?
is no proper treatment, it may leave the patient anxious.
So it has to be of benefit for the community, isn't it? If a person is going to live for 6 months more, okay, with just supportive care, we are investing a lot of resources and expertise in diagnosing this cancer, but actually it is not helping people live longer. It's as simple as that. We want to spend our resources on a cancer whose nature or natural history is known, and if we intervene early, we can actually make this person cancer free and live longer, isn't it? We want gains. Whatever we are going to invest in, we want gains. The gains are that person becomes free of cancer and is able to go back to leading a good life. Effective treatment and potential cure is possible. Okay, for screening, that is for a screening test, that is one of the requirements. Also cost. Okay, cost is one of the major reasons why mammographic population-based screening has not taken off in India. A mammogram will cost at least 3,000 rupees. The machine costs like 2 crores. Okay, with that you need a radiologist, and once you have seen a mass on the mammogram, what do you need to do next? You need to take a biopsy. That biopsy tissue sample has to go to the lab, and there are costs involved in transporting, reporting. And once you have diagnosed this cancer, what do? You have to treat it because you've invited a healthy person to come for screening. And by chance you detect a cancer, can you just tell them go somewhere? No. It's your responsibility to continue the process and give them the care that they need. And India is not able to achieve that at this point in time because of various reasons. It has to be a cost-effective method. For example, HPV. Okay. So I'm aware that I've got another maybe 6-7 minutes to 7, but because we started 10 minutes late, can I just push on for another 5 or 10 minutes beyond 7? Is that okay with you?
No problem, ma'am. You can continue, ma'am.
Okay. So for example, as you can see, HPV is an infection, a virus that gets into the genital system in women and men. And the DNA of this virus integrates with the DNA of the mucosal lining cells. Okay. And then it makes, because the DNA of these cells has changed, it has turned into a cancerous cell. And as you can see from the left side, the normal cervical mucosa moves to a neoplasia, neoplastic cell, wherein the cells are just mutating because of the cancer, because of the HPV DNA within their system, and then from there they've transformed into a invasive cancer. So this we know, cervical cancer is caused by HPV. We know the risk factor. We know the natural disease process, natural history of this disease. This is how it starts, this is how it progresses, and this is how it forms a cancer. And next, we know that cervical cancer is one of the commonest cancers, and once we catch it early, we'll be able to treat the woman completely. So this is a perfect cancer to actually start screening for. Okay, so in India, cervical cancer screening starts at the age of 30. Okay, and the screening tests are VIA, which is visual inspection with acetic acid. They spray acetic acid on the cervix. This can be done in an OP procedure. Okay, it's very simple, clinic-based, no anesthesia, very simple kits that you need and acceptable to women. Okay, in a gynae clinic or even a public health, setup like a district hospital, it can be done. So you put a speculum, spray some acetic acid, and you look for any lesions or changes. As you can see on the top, there are some white changes where the mucosa has become thickened and whitish. When exposed to acetic acid, you can see this. Or pap smear. It's a small brush that is just, rubbed on the cervical orifice, and the mucosal cells are captured and looked under the microscope. And now we also have tests to check for HPV DNA. These are all very simple tests that can be done in outpatient basis, and they are cost effective. So all women over 30 up to the age of 65 should undergo these screening tests during a routine gynae checkup. And then if these tests come back negative, you repeat the scan, repeat the test after 5 years. If it is positive, they get referred for a definitive biopsy. And on biopsy, on taking a biopsy, if there is, in situ cancer or early cancer, it is treated again in an OP procedure using cryo or LEEP, which is electrosurgical endoscopic removal of that abnormal mucosa. So it's a very early change. It has just started. It has not spread to the uterus. It has not spread in the pelvis or the lymph nodes or anything. This is stage 0. Okay, stage 0 or stage 1, you can completely cure it. Screening for breast cancer. As I said, in breast cancer, here in India, we don't do routine mammography every year for all women. We do, or for women who are over the age of 30, we do we encourage them to come for clinical breast examination. If they've come for some other reason, we obviously take the consent and do a breast examination to look for any lumps or other changes. Okay. If it is normal, they come back every year for a checkup. If it is abnormal, then you go ahead and ask for triple assessment, which means mammogram, ultrasound, and core needle biopsy. And we encourage our patients, all women, whether they are symptomatic or not, to do a self-examination. Every month after they finish their periods, they should examine themselves so that even if there is a small, that there is no pain in breast cancer. Can you tell me the symptoms that women feel when they have a breast cancer? Apart from a lump in the breast or a change in the breast? Nothing. They won't have pain. They'll be able to eat, drink, work, exercise, everything. Okay. So without a symptom, it is difficult to find that there is something wrong in the breast. So a self-examination regularly can actually help them pick it up. Breast cancer screening, as I said, is using a mammogram. Mammogram is basically X-ray of the breast. The low dose X-ray of the breast. The breast, as you can see, is clasped between two plates, and it is spread out and stabilized, and then exposed to X-ray. The clinical examination is done by it need not be a doctor. In our community, ASHA workers, ANMs, and medical officers, whoever are there at the grassroots level in the community, they can do a clinical examination. All right. Oral cancer, again, screening in India, it is very important. And someone mentioned leukoplakia and erythroplakia. You can see these pictures there. These are early changes. If the tobacco cessation is, prompt, and if these areas are successfully excised with minimal surgery, then the risk of developing a full-fledged cancer can be controlled. High-risk individuals who use tobacco or alcohol or betel nut, you do a visual oral examination. There's a chart there that looks at all the corners of the mouth. Okay, there's a method of doing it, all the corners of the mouth. And if it is normal, you encourage them to stop using the substance and come back for regular checkup. If it is suspicious, if you find something, you refer them to the next level, to the district hospital or something for a biopsy. Benefits and harms of screening. So I want some engagement from you guys. I want you to think about what is written on this slide and engage with me. Okay, we know the benefits. We know that it reduces the cancer risk. It reduces, the number of people coming with bad advanced disease. It reduces the number of people dying from cancer and the burden of society. All of that is good. What are the harms of screening? Adverse events. Can somebody comment on it quickly? Can you think of adverse events? Say, for example, when you're doing a pap smear or you're doing a speculum examination, or when you're doing, say, a colonoscopy, any screening test. Adverse events, especially in tests that require, maybe some medications or drugs. Allergies, anaphylaxis, is that right? For example, if someone is having a, cervical examination, if they go into a vagal shock, sometimes vagal arrest. Yeah. So these are adverse events. Some of the screening tests, although they are seemingly simple, they can have adverse events. Okay. So normal individuals who walk into the clinic for screening, they are healthy, asymptomatic. If they have an adverse event, that is a bad thing, isn't it? Because you've taken normal people and you have made them unwell. So these are some of the harms of screening that we need to be careful of when we offer screening to a population. Anxiety. Anxiety is real. Every time a woman comes for a routine mammogram, she's sitting there outside looking at all the pictures and all the other patients in the waiting room and thinking only about, have I got cancer? Have I got cancer? And after the screening is done, we'll tell them, go home, we'll call you for the results. And all night and all day, she's going crazy thinking about, have I got cancer? So anxiety is a real thing. And there is now evidence to show that a woman who comes to a breast clinic for screening, sometimes her anxiety can go on up to 6 months. Okay, these are normal, healthy individuals in whom we are inducing significant stress and anxiety. So these are the negative effects that come with screening. False positive results. What are they? Can somebody quickly define false positive?
When the disease is actually not present, but the screening tests say that there is risk factor.
There is cancer. Okay. You've
It
done
will
a
do low
test.
specificity.
Yes. So you've done a test and you have told them that they have cancer, but actually they don't have cancer. Okay? It's a it's a positive result, but it's a false positive result. Can you imagine how the person will feel? You call them, you've done this test, done a mammogram or examination, you find a lump and you tell her that, okay, this is cancer. And then after a detailed examination, we've done, I don't know, 2, 3 scans, whatever, more biopsy, everything, and then it comes back as no cancer. How do you think this person is going to react? Can one of you comment? Can you empathize with this person? What will they believe? Will they believe the first part or the second part? What are the effects of a false positive result on a person, on an apparently healthy individual? Any
They may
comments?
lose faith. They may lose faith in medical science itself sometimes.
Okay, maybe not so far. Maybe they'll just lose faith in this whole screening test itself.
Yeah.
Okay.
Okay.
Either they will convince themselves that they have cancer and we have not checked it properly. They might go from pillar to post trying to find this cancer that doesn't exist. They might subject themselves to, intense operations. Who you never know. They might be like, okay, there's something in my breast. I want to have an operation. They told me initially that it is cancer. Then they're telling me that it's not cancer. I don't care what it is. I want this removed. Okay. So they may undergo anesthesia, admission, removal of the cancer, removal of the breast, the harms and risks that come with it, the expense that comes with it. So all of that can be, or they might just lose complete faith and be like, this entire allopathy is useless and let me just do homeopathy or something else. Okay. So these are all the side effects of false positive. Similarly, false negative. If there is a cancer, you've done a scan and you told them everything is fine, you go home. False negative is really common with FNAC in breast, especially. They'll do an FNAC and they say that, okay, we can see only blood. There is nothing there, you go home. And then after 6 months, the patient has a big lump or a tumor that is ulcerating. Okay, false negative. So ideal screening test should correctly identify individuals who have cancer and also should identify people who don't have, should be confidently excluding patients who do not have cancer. Overdiagnosis and overtreatment. Can somebody comment on this? What do you understand by overdiagnosis? Overdiagnosing cancer, is that possible? Overtreating a cancer, is that possible?
We might confuse a benign tumor to a metastatic tumor.
Well, that is a false positive, false negative. It falls in that category. What is overdiagnosing cancer? Are there any kind of cancer or pre-cancer conditions that may be there in our body but don't actually kill us? Imagine I am 65 and I have a small, low grade, some pre-cancer change in my body. And if you hadn't caught it, I would probably die a natural death with it. It wouldn't have actually made me die earlier. Does that make sense?
A mole.
So overdiagnosis is, for example, there are lesions in the breast called DCIS, ductal carcinoma in situ. It is a precancer change, okay? When you screen normal people, you pick up DCIS changes, okay? Low-grade DCIS is very slow growing. In a 60 or 65-year-old woman, a small spot of DCIS is not going to, she may live for another, say, 20 years. In her lifetime, this precancer change is not going to turn into a cancer or progress into a cancer and actually affect her life. Okay, so by doing screening and catching these low risk small lesions and treating them, what are we doing? Are we actually improving their lifespan? No, she would have lived until she is 85 with this and until she is 85 even if you treat it. So that is overdiagnosis and overtreatment. This is more significant when you do population-based screening. Like in the UK, the example that I gave you about, a routine mammogram, they pick up a lot of small lesions that are very, very low grade and very small, and they don't actually affect these women. They don't grow into cancer, and they don't actually kill them early. So what is the benefit of overdiagnosing and removing all of these small things? This is also a potential harm. You're bringing these women for procedures and treatments that is not of much benefit. Okay, so are these clear benefits and harms of screening? Okay, so I'm moving on to my last couple of slides. Thank you for your patient listening. India is doing a lot. The government of India is investing a lot in, both preventing cancers, screening for cancers, and treating and rehabilitating cancers. It's a very complex plan. It's a very complex task. It has to be done at all levels. You have to educate the population and the people. You have to identify who is at risk. You have to gather data, first of all. Gathering a national level data on health in India is a nightmare because we don't have any system of, actually registering all the cases. Okay, everything is quite chaotic and quite disintegrated. No two systems speak with each other. Okay, so India is now trying to maybe streamline data collection to know what is the actual disease burden, how much of cancer actually is there in India, who is at risk, how are they getting cancer, and what we can do. So that data itself is now being gathered. So National Cancer Registry across 250 hospitals, cancer hospitals in India, are now contributing to a national database. That is how we know now that, okay, breast is more common. It used to be cervix, but for some reason, a variety of reasons, cervix is now being overtaken by breast. Head and neck cancers are more common in men because of smoking. So all of this we know because the government is very systematically gathering data in the last 1 to 2 decades. And screening has to start at the community level. As I said, ASHA workers, ANMs who frequently see these patients, they know who is at risk. They know who are the women who are postmenopausal. Okay, so and the community also should accept it. They know these people as well. They know their healthcare workers. So they'll be more acceptable to screening if it is someone who is familiar. So screening starts at grassroots level, and then they get referred to community health or district health centers if on screening if something is found, and then from there diagnosis like FNAC is done or a pap smear is taken, basic slide review, FNAC, all these will be done. From there they'll be referred to a tertiary cancer center for staging and treatment. Okay, so roughly this is what happens in our country at this point in time. So to summarize, cancer mortality in India is increasing. So these are the statistics from the website, the government's website. Smoking causes 1 in 5 deaths in men. Okay, that is really, really significant. 1 in 20 in women. 2,500 people die from tobacco-related diseases every day. Every day we have 2,500 people who die because of tobacco. So imagine if we could eradicate tobacco use entirely. Imagine the burden that would reduce. Okay, 50% of women with breast cancer die from it. Only 50% actually live their natural life. 50% of them actually die early because of breast cancer. 1 woman dies of cervical cancer every 8 minutes. So this is huge. The morbidity, mortality of cancer in India is huge. And these are statistics that we know. There are huge swarms of population whose statistics we still don't know. In some states, Kerala is quite, southern states are quite advanced. There are some states in the north as well where healthcare is better, awareness is more, data collection is better because they have got their cancer center. But there are large areas in India in which we don't know what is happening. So it is a huge public health concern. Okay. Prevention and screening, we need policy and framework. We need national programs. We need surveillance. We need research. We need NGOs, private players, public players, individuals, everybody to work together to be able to prevent cancer and to reduce the deaths from cancer. we should be moving on. I think India should be able to include AI and their digital advances to screen patients and create awareness. Thank you, everybody, for your patient listening. And if you have any questions or comments to make, we can address that now. I also want some feedback on how the session was, whether it was too boring or long or way superficial or deep, whatever you think. And thank you. I want to thank the organizers for this amazing opportunity. Thank you very much.
Ma'am, we do have one question in the chat box.
Mm-hmm.
So the question is from Shweta. It says, from your experience, ma'am, across India and the United Kingdoms, what single change would improve cancer outcome in our medical system?
I think health-related awareness. Health-related awareness is the single most important thing that will improve our our cancer incidence as well as mortality and morbidity associated with. And healthcare awareness should start very early. It is health awareness, sorry, not healthcare. Health awareness should start very early. It should start when children can actually are 8 or 10 years old, and it has to be persistent. It has to happen at every junction of their, of their progression through education. For example, people start smoking when they are 12, 13, sometimes as early as that. Children now vape as well. They use e-cigarettes and they use vapes whose harmful effects we still don't know. Maybe in 7 or 8 years, we will start learning about the effects when the research is mature. And about reproductive health, about breast health, and what to eat and what kind of lifestyle is good. It should start very early, and it has to be reiterated. It has to be consolidated at every level in their life. So when they become teenagers, when they go for go to universities, when they go to get their job, having healthcare health checks done during their pregnancy. So at every junction, health related awareness has to be reinforced. I think that alone will actually help us cut back some of the preventable cancers.
Thank you, ma'am. Ma'am, there is another one from Kirtana saying, how do we counsel asymptomatic patients who are reluctant to undergo screening?
So that is a very good question, actually. So in countries that have screening program, they do something called pre-test and post-test counseling. They invite the patient to, say, for example, if it is a mammogram, they invite the patient. They explain to them. They give written information about what test they are going to have and what it is going to detect, how much pain will it cause, and how much delay in what is the turnaround time for getting the results. And they will also tell them, this test is going to detect this cancer, and by catching it early, you will be able to cure it completely. So this kind of information is given pre-test. And once the patient agrees, it has to be voluntary. You cannot grab them and put them through a screening test. Okay, if a person is unwilling, you give them the information that you think is important, give them written information and let them go, and then chase it up maybe after a few weeks time. Say that, how do you feel about it now? Have you thought about it? Would you like to come back? So we can only nudge them, we can only encourage them in a positive way, but we shouldn't be actually forcing them. That has a much more negative, I think it'll push them further away from screening. They might be averse to screening because of a few things. Maybe they're worried about pain. Maybe they're just worried that, once the cancer is caught, then they're going to die. So things like this, you can bust these myths and actually get their consent for screening. Did I answer your question?
Yes, ma'am. Thank you so much, ma'am. The session was really nice and interactive, ma'am.
Thank you. I'm glad, to get that feedback. I think we've overshot our time significantly. Thank you so much for all of you, who are listening in today. If you have any questions or queries, you can, contact Sneha. I'm happy to share my email. And if it helps you in any way, academically or otherwise, I'm happy to engage with you guys. Thank you.
Ma'am, there are a few more questions in the chat.
Okay, go on. Yeah, go on.
Okay. So Aditya is asking, what are the common misconceptions regarding cancer?
common misconception is that cancer is equal to sure death. Okay, and the people who think about cancer, they see people, frail, thin people without hair, and who are on the pathway to death. One of my patients recently said that. She said, "I don't want treatment because cancer means death. I'm going to die anyway. Why should I go through all of this?" So that is a major misconception, and people believe that, and there are a lot of other social or ethnic aspects to it. Some people believe that cancer is actually a punishment. People who have a religious sort of outlook towards life, they think cancer is a punishment. If God has given this to me, I should suffer. Why should I treat it? So these are all quite common. When you actually open up and talk to patients, you'll realize that they look at cancer in their own way, based on their culture, their ethnicity, and their outlook in life, and that can be a major barrier to seeking care, actually. Next question.
Ma'am, it's from Zaria, which says it's related to pediatric oncology. Does pediatric malignant tumors are more influenced in prenatal events or postnatal factors are more influential?
So my knowledge of pediatric oncology is very poor. I'll accept that. I think I read pediatric oncology when I was maybe your age, at your level, MBBS, and probably a little bit during my MS in general surgery. But from what I understand, majority of the pediatric cancers are genetic. Okay, so they are defined by their prenatal risks, genetic risk, and genetic cancers often present very early in life, in the first 1 year or 2 years. But there are non-genetic pediatric malignancies as well, like, for example, leukemias, okay? Lymphoid leukemias, which are common. They may not be because of genetic risks. It can be environmental or just random mutations in the body. Okay, so that is all I'll be able to say at this point in time, because my expertise is as good as yours in pediatrics.
Thank you, ma'am. We have one more from the YouTube live session from Aravindan asking, what is your perspective of AI in screening cancer diagnosis?
AI is excellent. I think India can make the most of it. Where you cannot put people, actual people with skills, you can put AI. It's, for example, if you need to screen, this is just an example. If you need to screen patients in the community for breast cancer, if you have a machine, and if you know a person, a trained person who can actually get these mammograms done, all the mammogram films can be transferred to the hospital or wherever. It can be transferred to an algorithm that will sit and look at all of these mammograms and pick up only those mammograms who have tumors and send it to the radiologist. So if you screen 100,000 women with mammogram, you will be able to pick 100 mammogram. The AI will pick 100 mammogram, and the radiologist will actually have to see only those and decide who needs a biopsy. Okay, right now, what is happening without AI, humans are doing all of this. Or looking at the FNAC slides, looking at the microscopic slides. You can take digital pictures of microscopic slides and ask AI to screen it. And if there is any morphological change, it will highlight it to the pathologist. So it's an excellent tool. Even awareness, engaging with patients, collecting patients' data. How many of us actually sit and ask the same question to the patients again and again and again? AI can actually help more integrated care.
Okay, ma'am. Thank you, ma'am. So here, I think we come to an end to our Q&A round. I would like to ask Shweta for giving the vote of thanks.
As we conclude this enriching academic session, it is an honor to propose the vote of thanks. On behalf of the organizing team and all participants, I extend our sincere gratitude to Dr. Sadamini Naik ma'am for her outstanding lecture on cancer screening, prevention, and treatment. It's not only the academically profound, but it deeply inspiring the modern oncology. Her vast clinical experience and global perspective have truly broadened our understanding. We are gratitude to you, ma'am, for your time, for your expertise and vision with us. And also thank our respectable organizing team for their guidance and support. With this, I conclude the vote of thanks. Thank you, ma'am. And let us carry forward today's learning with purpose and compassion. Thank you, ma'am.
Thank you, Shweta.
Thank you for the wonderful session.
Thank you. Thank you very much. Have a good evening, all
Thank
of
you
you.
so much, ma'am.
Bye.
Bye, ma'am.